Good evening and welcome to our PRI Breathing Mechanics in COVID Times webinar. We are on week 7 and tonight's title is Maximizing Mechanical Reciprocal Respiration Force through the Integration of Intercostals, Wrist Extensors, and Ankle Dorsiflexors.
It's a lot of wording. A long sentence, long title. Welcome everybody, and thank you for joining us, and thank you for inviting Jen and I into your Adobe's, your home or your office. Week 7, Jen. I look back on the previous 6 or 7 weeks before we got here today, and we're actually at a place where I wanted to go that second week immediately, and that is to talk about forced respiration and these intercostals. You got 2 sets of them. You've got an internal set and you've got an external set. And tonight's going to be kind of a fun night. I'm sure I might lose a few of you. I don't want to. But I'm going to tie in what I believe is incredibly important when you start to look at the likenesses and dislikenesses of the abdominal oblique muscles that we touched on last week, and these things called intercostals. And intercostals are the core, if you will, I hate to use that word, of our thorax, and you're going to see why here as we go through this next hour. And they are the central part of your system because they line the bottom of one rib to the top of another. And their ability to recognize what you're doing with your appendages is 1-to-1. So when you raise a wrist into extension, when you do that, when I lift up my wrist, I know my intercostals are going to know that. There was no rotation. There was no lateral flexion. I just raised my wrist up. If I go down to my heel and I pick up my toes off the floor, I know I'm going to have to come forward with my thorax, and I know my intercostals are going to know that. There doesn't have to be any rotation. There doesn't have to be any lateral flexion, but I know they know that. And then we call that proprioceptive neuromuscular facilitation. So tonight we're going to talk about PNF. And I have been waiting to talk about PNF, Jen, for many, many years, actually. And to find a place to talk about it, you had to build 6 weeks prior to this time. And by, I think, week 9, when we put it all together, you're going to see I think, a good novel unfold. So tonight is going to be a little confusing. I'm going to move around a little bit, but when am I not moving around, and when am I not a little confusing? But I want to take a minute and remind you that the techniques in the handout are technically the last 3, I believe, of 10 techniques that this webinar series is covering. The 3 that I selected for this handout was selected before we even started the webinar series for the title, Maximizing Mechanical Reciprocal Respiratory Activity with force. You might want to underline that word force. By integrating your intercostals with your distal lateral wrist extensors and your distal ankle dorsiflexors, your lateral ankle dorsiflexors. Those ankle dorsiflexors and those wrist extensors were described by Margaret Knott and Dorothy Voss way back. 1956, they wrote their first edition. I believe this is 1968's edition, the second edition, and Jen tells me there's a third one. This manual I lived with next to my pillow in my bed at night, and you'll see why when we get into this. These 2 people were, and still are, mentoring me to this day. And there isn't enough time in 1 hour to go over D2F and D1F activity as it relates to forced respiration, but I'm going to give it my best shot in an hour. And you do have a handout that I think many of you have gotten from Jen. I'm going to follow that handout. I'll do the best I can to stay under an hour. We might go over a few minutes, Jen, again.
All right, you're good.
Am I doing something wrong? A muscle contained wholly within the organ on which it acts is called an intrinsic muscle. And I quoted muscle contained wholly within the organ on which it acts is an intrinsic muscle. Because if you type in intrinsic, that's what you're going to read. A muscle that's contained within a boundary, and it acts within a small boundary especially is called intrinsic. And these intercostals are intrinsic muscles. There probably is not a better example of core intrinsic muscles than the intercostals that go between your ribs. I apologize if this slide is makes you uncomfortable, but I love this slide. This is a deer that my son shot a year and a half ago, and he processes his own meat. I happened to help him clean this animal, and I said, RJ, if you could just stop for a minute, I'm going to grab my phone. I got a step ladder, and this animal was hanging. We cleaned out the inside of the carapace, or the inside of the carcass, with water and cleaned it all off. But you can see in this animal's inside thorax a beautiful representation of intercostals that are internal intercostals. That animal could not move in life if those ribs were not held together by intercostal guidance. And we have those same muscles in your rib cage. We never talk about them. They're proprioceptive, neuromuscular, facilitatory muscles. They are directly in communication with all your extrinsic muscles on the outside of the body. And they were not meant to rotate your trunk. They were not meant to laterally flex your trunk. They do. They get caught up in the act. They were meant to stabilize your trunk. They were meant to give you intrinsic core control when you're in this position. This position is someone getting either in a chair or out of a chair, getting on a toilet or off of a toilet. You're somewhere in a transition between standing and all fours. Those intercostals you're looking at is on an animal that was on all fours all of its life. That animal had to have those intercostals to move forward and backwards with its legs, and it's got 4 of them. Now, we don't walk on all fours. We're in transition. And last week we talked about these muscles called the abdominal muscles, or the internal and external oblique muscles that are on the outside of the body. They're the rotators. They're the lateral movers. They're your mass shifters. The intrinsic muscles have to be in a good position to counteract their pull, so you can do that without your ribs falling apart or flying out when you jump fences, run, or climb ladders. The primary muscles responsible for the expansion and shrinkage of the size of the chest and the size of the animal that you just saw to facilitate breathing are your intercostals. The intercostals' number 1 role is to make your chest either look big or look small. The inner intercostals are your exhalers. You don't have to write this down, it's all in that handout. The external intercostals are your inhalers. So they're breathing muscles. They do very little for your breathing, but they do a lot when you're forced to breathe, when you're out of breath, when you're trying to lift, when you're trying to adjust for the weight of your body on all fours, or when you're sitting or going from sitting to standing. Anytime you use the word forced or force, the intercostals are involved. Light forces will not really demand much out of your intercostals. So any weightlifting you do, which includes holding your body weight up, in transition specifically between the 2 acts of movement from one side to the other, is going to involve your intercostals. And after gaining or regaining extrinsic control of the left internal oblique abdominal muscles and unobstructed airflow, which we talked about last week, and it was a great, I think, discussion about that first part of that sentence, unobstructed airflow, by getting your left abdominal obliques to kick in, and by maximizing mechanical reciprocal ribcage function for more optimal breathing efficiency, then your intrinsic intercostals rhythmic stabilization is going to kick in. For efficient intrinsic intercostal rhythmic stabilization, you have to have ongoing extrinsic control of the diagonal planes that you own. And the diagonal planes, Jen and I will tell you, are based off of frontal planes, Jen, and transverse. So that's kind of an important slide, because this evening we wouldn't be able to talk about intrinsics if we didn't have last week behind our belt. The facilitation of breathing with these intercostals is enhanced by PNF, Margaret and Dorothy concepts, and integration of these concepts with distal appendage movement. PNF is a distal appendage movement concept. It's distal diagonal activity between distal sites in your body, your fingertips to your toes. And for you to do that distal diagonal activity, to breathe correctly, you have to have some pretty solid construction between rib cages on one and the other side. And you've got 12 of these things. They're called 12 ribs. And these ribs have these muscles that are sandwiched between them, and it make you look like a turtle or a carapace. And that carapace does two things because of these intercostals. During diagonal movement, it'll either expand or it'll contract or can close down. So when I move my wrist back into extension, I'm expanding. And when I do that, when I take a good deep breath of air in, I know my external intercostals are firing for me to assist with that. If the timing is off because of where my ankle is, my external intercostals may act like an internal, my external intercostals may be an exhalation muscle instead of an inhalation muscle. The next thing you know, you're going in these states of extension, which we'll get into, not of the wrist, not of the ankle, but more of the back and more of the side walls of your trunk. That's called tension, tightness, sympathetic tone, extension, tightness. This discussion tonight will address the facilitatory relationship between forced inhalation and wrist extension. Forced inhalation and wrist extension. When you move your wrist out, you're going to have to breathe with forced inhalation now. Not quiet inhalation, forced inhalation, which we all need once in a while. A cleanse, a push, a pull that's forced. And forced exhalation and ankle dorsiflexion. So when I see the word dorsiflexion, and it's coming from your ankles obviously, I know that you're getting forced exhalation activity somewhere in that rib cage to maximize inter-rib mechanical reciprocal respiration. Your intrinsic muscles give your extrinsic breathing muscles the capability that they have in keeping you honest and keeping you alive with two zones of apposition underneath of them. So this relationship between intrinsic muscles called intercostals and the appendages you have are critical once you've established neutrality of the thorax with the previous 6 weeks of information we just went over, the last 6 weeks. We're now going to do something that's going to be more beneficial for once you've got your internal obliques and your TAs alive on the left side and your EOs on the right side working correctly. What are you going to do to maintain neutrality every time you start to push or force yourself either in and out of a chair, picking up a wheelbarrow, picking up a 50-pound sack of salt, whatever it might be? Because underneath that force, you're going to go back into your old pattern if you don't tie in wrist extension and dorsiflexion correctly with these intercostals. Humans use extrinsic abdominals to rotate the thorax diagonally and shift the thorax laterally. I said that earlier, which we discussed last week. This week, we're going to talk about intrinsic intercostals that are shorter, they're smaller, and they're more stable than the extrinsic abdominal muscles. I've said for years, Jan, you've heard me say this, I don't like the word core. When people use the word core, I understand what they're talking about. It's not that I don't like the person who used it. I just don't like the concept they're using it with. Our number one core is not your abdominal muscles. Your number one core in your body is what holds your ribs together. Abdominals do not hold your ribs together. Intercostals do. And let's pray to God that you got them, because if you didn't have them, your abdominals are useless. Now, the reason why people can't kick in some of their abdominal muscles diagonally is because they don't have control of forced respiration. They can't push themselves and pull themselves around, getting into and out of things with correct dorsiflexion of their ankles, and they can't manage things in front of them with wrists that extend. So Margaret and Dorothy will tell you that if you really want to kick in diagonal activity with your thorax and your body, you've got to have wrist extension. You got to do something with the distal appendages you own if you're going to get your core mindful of movement during respiration. They, along with the wrist extensors and the bilateral extrinsic abdominals, assist in moving the thorax forward while getting in and out of a chair. And along with the ankle dorsiflexors and bilateral extrinsic muscles, assist in moving the thorax backwards when going to a chair. We need dorsiflexors to sit down, and we need wrist extensors to get up. When I get out of a chair, if I take my hand and I move my hand back, I'm not going to get out of that chair. But to get out of that chair, if I move my wrist into extension, like I just did, my entire intrinsic center of my brain says, well, you got force. Go ahead and use your plantar flexors and get out of that chair. Wrists diagonally control what you do with your core stability, provided you understand that you've got to have an ankle that's going to permit you to do it. When I go back into a chair, I've got to bend my knee forward, bring it forward, but I got to do that through dorsiflexion. I'm never going to sit in that chair comfortably if I can't lower with my ankles going into dorsiflexion. Now, I know I'm trying to be callous or mean, but nobody's sitting in a chair and getting out of a chair without these intercostals permitting it. Because if the intercostals are not in a position to allow that flexion to occur in that thorax, that wrist extension, you can do all you want, and that dorsiflexion, you can do all you want. You'll hit the chair with a hard thump because your back is too erect, too straight. Intercostals do not like straight backs. When intercostals get on straight backs, they act like abdominal muscles. Sometimes you hear people say, I've got a stitch in my side when I run. Well, that's because you've got these intrinsic muscles that are working as extrinsic abdominal muscles, because your abdominal muscles are not in the right position for rotation and diagonal direction. I know it's got a lot of material, and I always so appreciate Jen. They still have an opportunity to go back and listen to this. Is that correct? Yes. Our most proximal central part of our body's rhythmic stability is patterned off of neuromuscular mechanical reciprocal respiration that's facilitated by the most distal lateral parts of our body. Your radius, your radial parts of your wrist, and this fibular part of your lower leg. And the musculature that is most responsible for isometric contraction during forced inhalation and forced exhalation of antagonistic and agonistic co-contraction without losing control of the thoracic stability are the intercostals. Very powerful slide. I had fun putting this handout together. In these weeks, I only have an hour. Jen only gives me about 30 slides. And so every word means something. And this is a condensed discussion about the relationship between antagonistic and agonistic muscle that is important for you all to understand when it comes to the internal and external arrangement of the musculature that goes from between rib and rib. We're going to talk about things called rhythmic stabilization. And this particular area we're in is a constant interplay between muscle fiber going one direction on immediate muscle fiber next to it going in the other direction between each rib of your body for either forced inhalation or forced exhalation. And we all need that in order for us to have quiet respiration. If we don't have quiet respiration, we're constantly trying to get extension. And if we can't get that extension, we'll flex our forearm, we'll flex our wrists, and we'll plantar flex our legs. Once you plantar flex your leg and you lose your dorsiflexion, your body's now going into extension, which is exactly what we're trying to avoid from day one with this webinar series. So you can see I've been waiting for this, and this muscle is really important for us to wait for. It's so important because it's the best neuromuscular muscle we have that governs and grades our overall trunk stability. That's major. It not only governs and grades it, but it controls it. And it controls it with the wrist extensors and your ankle dorsiflexors. Now, the muscle between your wrist extensors and dorsiflexors are all interplaying on this activity, but it starts and stops with D2F and D2Es and D1Fs and D1Es. And we're going to pick two patterns this evening. We're going to talk about D2F and D1F as it relates to the trunk. Specifically, the wrist extensors facilitate external intercostals effectiveness of rib function. So when I move my wrist like this, think external intercostals, think inhalation. And the ankle dorsiflexors facilitate internal intercostal effectiveness of rib function during forced exhalation. Two parts of our body that kind of controls how you're moving your body's intrinsic intercostals. And it's kind of easy, Jen, because we're not talking about things that are this or this. We're not talking about things that are this or this. We're talking about things like this tonight. And that's more important than anything at this stage in the webinar, because once you get your trunk rotation where you want it, once you get your mass over your left leg, and once you get the activity that we're desiring from our diaphragms with perfusion, our ventilatory activity now is going to depend on how well you can force things out, like blow into a balloon or lift your body weight up. Because if you can quietly do everything up to week 7, now we're going to put the grind on you a little bit. Now we're going to make you work. We're going to make you a little bit more, we're going to put more demand on you. And humans need demand. We were built to lift. We were built to work. We were built to push, and we were built to produce a word called force. That's what we were built for. And it starts with starts with those muscles that go between those ribs. I put together a short little overview of the intercostal, wrist extensors, and ankle dorsiflexors as it relates to postural respiration. First of all, let's talk about what these muscles really are when it comes to respiration and posture. The intercostals on the inside of your rib cage, closer to the pleura cavity, aid in forced expiration. Quiet expiration is a passive process. Quiet activities, a passive process when it comes to getting air out. But in forced expiration, these internal intercostals play a very, very important role. They attach to ribs 2 to 12 and ribs 1 to 11. Their fibers pass anterior and superior from the upper margin of the rib and costal cartilage to the lower margin of the rib that is above it. The internal intercostals are responsible for the depression of ribs and bending of the ribs inwardly, thus decreasing the transverse diameter and dimensions of the thoracic cavity. I love this slide because you can see the orange. Do they have color on this too? You can see the orange is the external intercostal going from rib to rib, and the light green is the internal intercostal. And then you got this wonderful muscle that's a little darker green on the outside called the serratus anterior. But what I really like about this slide is that on the other side of that rib, on the other side of that internal intercostal, you got pleura cavity. So when we skinned that animal that RJ shot and cleaned it all up and washed it all out, we took all the lung out, we took all the pleural cavity out. I've done that a lot in my life with a lot of cattle. And when you get in there, you start looking around, it is one of the neatest cores you're ever going to see. And we all have that core. And that core is completely controlled by those layers of muscles that go from rib to rib. And they cross each other. They're in a crossed pattern. They have two different roles and two different functions, as we just got through discussing. It is incredibly important for you to appreciate that the space that we have between each one of those ribs is sensed. Next week, we're going to talk about sensory processing disorders of the thorax. And I want you to take a minute and look at the nerve, that little green nerve that's laying under the artery in the intercostal vein. That's next week's discussion, Jen. Because our ability to sense who we are comes from 12 pairs of that little nerve. So external intercostals aid in quiet and forced inhalation. They are attached from ribs 1 to 11 or go to ribs 2 and 12. Their fibers are directed obliquely downward and laterally on the back of the thorax and downward and forward and medially on the front. Is it Lomberger baskets? Is Lomberger one that made baskets? Lomberger? Well, anyways, someone shake their head. Is it Lomberger baskets? How do you say Lomberger? Anyway, they're like a basket, a woven basket. They are responsible for the elevation of the ribs and bending of the ribs more outwardly or more openly, thus expanding the transverse dimension of the thoracic cavity. There's another slide of them. So you got your inner intercostal area. It's basically a wall of pleura, if you want to know the truth, followed by your internal intercostals. And look at those external intercostals laying next to the internal intercostals. So those ribs are constantly shifting, and I was going to grab a couple, but they constantly shift on each other, forward and back, but they really don't do much motion with diagonal work. They're there to keep the carapace, keep your cavity from flying around. The extensor carpi radialis longus. Can you believe it? We're talking about intercostals, and then he throws this slide up there. Kind of crazy, isn't it? But these guys, who they are and what they do, control what we just left. Or not even control them, guide them. So we got this extensor carpi radialis longus. It aids in quiet and forced inhalation when the ankles are in a state of dorsiflexion. Talking about them in a group of not even parafunctional, not even what I would call polyarticular muscle at this point. They're working together in a diagonal way, if you will. This long muscle attaches to the lateral side of the humerus and to the base of the second metacarpal bone, or metacarpal of the index finger. It should say base of the metacarpal bone. It is responsible for extending the wrist and deviating the wrist towards the radial side. So that you have a good picture of that extensor carpi radialis. It takes that wrist, extends that wrist, and moves it towards the radial side. So that's what that muscle does. So when you go up, if you start here, that would be extensor carpi radialis. I'm going to continue. We happen to call that D2F if you look at PNF material. But it's extremely important for you to know that that particular muscle assists, I'm going to go back, in this assistance in quiet and forced inhalation. It's assisting that when the ankles are in a state of dorsiflexion. This wrist won't work correctly with those intercostals if you cannot get your ankle to dorsiflex. If your ankle is plantar flex, this wrist has no purpose. You're already there. That rib cage is not going to really respond to that wrist. Dorothy knew that, and Margaret knew that. So they put the arms and legs in certain positions to make sure that material between this distal extremity and the contralateral extremity is in a state where one can influence the other. One can reduce the effectiveness of all the abdominals of your body, all the zones of apposition of your body in the chest wall, if they're not working together. And that's the beauty of their work when you look at proprioceptive diagonal patterning. So there's your radial deviation and your ulnar deviation. Let's talk about the tibialis anterior. The tibialis anterior aids in force exhalation. So when those wrists are in a state of extension and you use your tibialis anterior, you're going to be able to blow out air. That's why many people will hold balloons like this. They'll put the balloon in their hand, they'll extend their wrist, they'll bend their knee, and they'll dorsiflex. Dorsiflexors, specifically the tibialis anterior, is one of the best exhalation muscles you've got, not because of what they do for the extrinsic muscles, but because of what they're doing for the intrinsic control patterns that are associated with forced exhalation. Coughing is forced exhalation. Spitting is forced exhalation. Anything that comes out of that mouth forcefully. This long muscle attaches to the lateral side of the lower tibia and to the base of the first metatarsal. It's responsible for dorsiflexion of the ankle. It inverts the foot, and we call that tibial deviation. So radial deviation, along with tibial deviation, empowers your intercostals. There's a good picture of the anterior tib. You can see the arches, see how it pulls the arches up, invert the foot. Here's another good picture, thank you, Jen, of ankle inversion. The top picture is, as you can see, those muscles on that top will do that to that top picture. This came out of it's from Pansky. It came out of one of our, I think it's at the I&I. And it's the very first one, says tibialis anterior. You've got the extensor digitorum longus underneath of it, the peroneus fibularis longus, and the peroneus brevis. All four of those are anterior lateral leg muscles that help with dorsiflexion. Now I want to kick in, that was a brief discussion about four muscle groups. And yeah, I saw that, yeah. But the top two, they all assist with basically supporting the fibula, but the top two are dorsiflexors, you're right. And Jen, thank you. That was quick. That was a quick, dirty little operational activity telling you about four muscles that I believe are extremely important for breathing, for respiration, for control of your core. Now I want to talk a little bit about rhythmic stabilization, two words that meant a lot to me early on in my career. Rhythmic stabilization of agonist and antagonistic muscles. Implementing that in terms of facilitatory activity for someone who had maybe a stroke or someone who had trauma, and we were trying to get back activity from muscle that was traumatized, the nerve was traumatized, and we're trying to retrain a forearm or a leg. And I really liked PNF, but I didn't like the fact that it was never looked at as a way of getting universal, holistic activity back. It was usually developed around thinking therapists were usually developing it for or using it for appendage and appendicular activity, but it has a major impact on your axial skeleton, as you can see, because of its its relationship to intercostals. So we're going to talk about implementing rhythmic stabilization and proprioceptive neuromuscular facilitation in the next few minutes, called PNF, of agonistic lower extremity D1F and upper extremity D2F muscle to maximize reciprocal respiration, which is inhalation and exhalation. That's a mouthful, but it's a slide that I put together, and it's a little talk I put together. It finally allows me to talk about a little bit of PRI, if you want to know the truth, with PNF. Now, you don't have to go pull out your old books and you don't have to pull up the PNF book. I summarized some of this in this handout on what D1F is and D2F is, and hopefully it'll make sense to you by the end of the talk. The word rhythmic and the word stabilization go hand in hand because they employ isometrics. We want isometrics of both the antagonist and the agonist to hold and sustain our body from shuddering and shifting and falling apart when we want good control. And, you know, doing that with appendages gives you the ability to start sensing what's necessary to either facilitate one side of the arm and leg while you inhibit the other. And it's brilliant work. It's brilliant work by our neurological system. But we also have that same type of activity going on between the two ribs. You've got an internal and an external intercostal, and they're doing opposite things to stabilize rib patterning and rib rotation. So when we look at the results of co-contraction of antagonist, if the isometric contraction is not released during the holding phase of the exercise, you get rhythmic stabilization. When Dorothy says, Margaret says, I don't want you to break, you know, I want you to hold it. Don't break, don't let it go as I push or pull on you. As you hold that phase of that activity, that exercise, you're getting both antagonistic and agonistic activity that's sustaining an isometric position because of concomitant isometric contractions of muscles that are going in opposite directions. You have their book. The second edition is the one that I rely on. And that's a little bit about rhythmic stabilization. I would encourage you, did you put the pages on there, Jen? Pages 97 and 98 in that second edition have a great discussion of rhythmic stabilization. Now, there is nowhere in the body, in my humble opinion, Louise, there's nowhere else in the body, in my humble opinion, where you're going to get more rhythmic stabilization, universal rhythmic stabilization than with those intrinsics. Than with those intercostals, I'm sorry. There's nothing that's going to give you and offer you that ongoing rhythmic stabilization without any therapist, you know, holding their hand on your rib and say, can you push into my hand and hold it there and hold it there and hold it there as I move that rib in and out and hold it there and hold it there to activate and facilitate one of those ribs intercostals, or two of those ribs intercostals, one of those intercostals between those two ribs, and then shift gears to the other one quickly without any movement occurring. Now, when I force my air in, that's essentially what's going on. Rhythmic, because then I take a breath of air, what? Out, I blow it in, I blow it out, I breathe in, blow it out, breathe in. That movement that you see is not great between each one of those ribs. It's going to add up for good movement, but there's a lot of rhythmic stability going on between each one of those ribs from this agonistic and antagonist relationship. So if I blow air out, I'm using my internal intercostals. If I breathe in, I'm using my external intercostals. If I hold myself steady for Valsalva lift and force, I'm using both. And when I use both, that's called rhythmic stabilization. So inside your body, you've got ongoing rhythmic stabilization without any therapist or athletic trainer or anybody working with you, constantly going on, depending on if you're doing it under forced conditions. When you move your arms away from your body or your legs away from your body, you have to work those arms and legs under forced pretense. And that forced pretense is not coming from your abdominal wall. It's coming from a serratus anterior that you saw earlier that's holding a shoulder blade onto a rib cage. Or a scapula, a hip that's holding your legs in position for your ankles to work. That stabilization, that holding phase of our body comes primarily from those intercostals between those ribs, primarily. So rhythmic stabilization to me begins with your intercostals. Now we have a lower extremity PNF pattern called D1F. And D1F has hip flexion with it, adduction with it, external rotation with it, dorsiflexion with it, inversion with it, and tibial deviation with it. If you look it up, that's D1F. And that's what we're going to try to demonstrate this evening with a couple techniques, 3 techniques, on how to get this intervening going on with hip flexion, adduction, external rotation, dorsiflexion, underline the word dorsiflexion, and some inversion and tibial deviation. Our upper extremity PNF D2F pattern of treatment intervention, shoulder flexion, abduction, external rotation of my radius, supination of my forearm, thumb extension, adduction, and external rotation, and finally, radial deviation. That's called a pattern of diagonal to flexion that Dorothy and Margaret named and numbered. And that pattern, along with D1F on the previous one, of the lower extremity, is what's going on 2 sides of your body. The PNF D1F pattern would be something I would want to have occur on the left side. And up until today, we've been talking about this on the other series, the webinar series sessions. We've been getting people over to their left side. So today we can start talking about this D2F pattern. Every time I hit this, they have this. Is that right now? This D2F pattern with your right shoulder, your right wrist. So think of the word right for upper extremity, left for lower extremity in this handout. And with this, these concepts, because we really want to do everything we can with corresponding, if you look at the word radial deviation and look at the word tibial deviation, yeah, tibia. Think of radial right, tibia left. Upon inhalation through the nose, the antagonists are the internal intercostals. Right internal intercostals for PRI right BC pattern humans. And the agonists are the external intercostals, right external intercostals for the PRI right BC pattern humans. And the extensors, the extensor carpi radialis longus, right extensor carpi radialis longus for PRI right BC pattern humans. What I did is I took that muscle associated with those diagonals and put a little PRI madness to it by naming the word right with it. So right extensor carpi radialis longus and right internal intercostals work hand in hand if you want right brachial chain effective activity with good synergistic activity coming also from the intercostals that are associated with that diagonal movement. So there's a picture of the extensor carpi radialis longus. And you can Google these things, look it up, but it goes on the radial side of your forearm. And then upon exhalation through pursed mouth, not your nose, the antagonists are the external intercostals, the left external intercostals for PRI BC pattern humans, and the agonists are the internal intercostals, left internal intercostals for PRI right BC pattern humans. And the tibialis anterior, the left tibialis anterior for the PRI left AIC pattern humans. So if you were not a PRI person and you just took the brackets out of that sentence, it would say this. As in the previous sentence, I could have done this, the previous slide, I could have done the same thing. Upon exhalation through the pursed mouth, the antagonists are the external intercostals, and the agonists are the internal intercostals, and that's all you would have had it say. And the tibialis anterior. I'm sorry, I forgot that. So keep in mind, they only put the brackets in there so you can understand that if you're thinking about PRI and pattern humans, I'm going to stick that bracket in there so you know what I'm thinking about when it comes to right BC and left AIC human being patterns. It's a good picture of the, thanks Jen, you did get in there, the left anterior tibialis. So when I see anterior tibialis on my patients who have difficulty with breathing, I think left anterior tibialis. When I see when I see people talk about wrist and D2F work, I think of right extensor carpi radialis longus. You are too thinking about it, because when you pick and select techniques like we're going to do this evening, those muscles are engaged in that activity with that technique you chose for that intercostal function that corresponds with those techniques. The summary of rhythmic stabilization reciprocal respiration as related to PNF and PRI integration. Now, this is where I know I'm probably losing some of you, and you've got a handout. You can go back and look at this material, study it a little bit. I'm intentionally kind of challenging you at this point a little bit. If you didn't, if someone's on this webinar tonight and doesn't really understand the PRI world we're in, not to worry. Just think about wrist extensors and ankle dorsiflexors and you'll be fine. And then forget about this BC stuff and this AIC stuff. Just think about right wrist, left foot, and you'll be fine. But I want to make sure the science, Jan, is complementing worlds that I grew up in called PNF and worlds that I kind of created called PRI. And for the first time, Louise, you're seeing this oval say, summary of rhythmic stabilization / reciprocal respiration as related to PNF and PRI integration. We're going to put the two together as relates to this series on breathing. So on the left side, we have these internal intercostals that need to help us out with forced exhalation. That needs to have a D1F pattern associated with it called ankle dorsiflexion on my left side, Louise, all on my left side. This is PRI stuff, but I sprinkled some PNF stuff in here, along with some intercostal stuff in here that we normally don't talk about because you can't touch it. It doesn't move much, and most people don't think it's core. So I got to make sure we got 6 other talks that got us to this point so we can get into the sensory component once we understand the mechanics. We repositioned people up to this last week. We got the abdominals involved. We got the floor involved. We got perfusion, and we took care of all this dead space. What are we going to do with it once we get there so we don't walk out of this mess we were in? We got to combine our intercostal activity with force. Because all of you get in and out of chairs, I would hope you would. You got to get off of the surface through force. You've got to push and you got to lower. That's why this talk, I think, is so imperative to understand. This requires tibial deviation. We need tibial deviation on the left side. We need tibialis anteriors working on the left side. And we need to push and hold down the outside of our foot on the left side. So that lateral little bone out there, that outside fifth met bone, it's got to be pushed on that ground. We got to figure out how to invert that foot so the right one can evert. So we can get our body over here and we can feel how that D2F patterning is going to secure my internal intercostals on my left side so that my right external intercostals can help me with inhalation, so my left one can help me with exhalation. Boy, it sounds like a PRI course, doesn't it? Now, a lot of information in a short amount of time. But this science is so supported by history, by people like Margaret and Dorothy. But you got to understand neuromechanics of not only respiration, but neuromechanics of diagonal rhythm. Diagonal rhythm. Otherwise, stabilization from abdominal wall or from glutes is not going to make sense because that inside of your chest wall that houses your pleura is not going to expand well on the right side, as we talked about earlier in these series. It's not going to open up the back side and the left side. I love this slide. I have a tough time leaving it. This is what our goal is. This is a big slide. We need this. This is life. This is what we all got to be generating our activity around. Every one of us should be thinking a little bit more like Margaret and Dorothy. Diagonals. We got to be thinking about diagonals. Jen and I had a wonderful talk about it. It's not a world of plane work, PLANE work. We don't have planes just of frontal movement, just of sagittal movement, just of transverse movement. We've got this diagonal stuff going on. And diagonals are really important if you're going to maintain good intercostal stabilization for rhythmic events called forced inhalation and forced exhalation. All allows you to oscillate better with extrinsic feel, which is next week, called oscillatory sense. The right side of your body, you need external intercostals. You need those outside muscles of that inner rib space. Forced inhalation is important. Forced inhalation. Wrist extension, D2F. You have in your handout. Radial deviation. Extensor carpi radialis longus loves that anterior tib on the left side. It's called, 1/2 of a forward locomotor movement process under force. Push and hold down your outside finger. Remember those days, Louise? Push and hold down into my hand, your outside finger. Remember that? Get that out there. I know you're a multi-sensory minded clinician. Get it out here. Because once you get it out here and you're pushing on me, that intercostal wall on the external side knows it. And that means on that right side, it's promoting facilitatory activity of the left intercostal's internal fiber to allow you to maximize that diagonal length so you don't stay short on one side and only get long on the other. This is all complementary of looking at two worlds, the PNF world and the PRI world that's biased. Just like Margaret was biased and Dorothy was biased. You have D1F and you have D2F. There's biasness, there's patterns of neuromuscular facilitatory activity. So we're going to now start, that was a lot of material in a short amount of time, but I sprinkled enough there that you can reasonably make sense of it if you live in multidimensional worlds. You live in a world where you're looking at intrinsics, called internal and external intercostals. You live in a world that's called patterns of movement that's called PNF. And then you live in this world of biasness that says the right side of the body's carapace is a little different than the left side. The inside of your body is a little bit different on one side than the other side inside. Now, we're going to show you three pictures of three techniques this evening. Jen, I'd like to read the first one, and I'll comment on, I think what I'll do is I'll go through it, but I'm going to have you read it first. And if we can get through the first one this evening, I'll tell you some of the other thoughts I have on the last two. But all three of these pictures, I don't have enough time tonight to show you how to lateralize wrist extensors on one side or lateralize, the ankle on the other side, the lateral ankle on the other side tonight. But I'm going to tell you what I would do with some of that concept theory with these techniques that we're going to select. The three that I selected have been around for a long, long time in our course work and our institute. And the thing I like about all three are kind of very appropriate for this discussion, because all three, you're going to see wrist extension and you're going to see dorsiflexion. And if you look at all three, you're going to see this description, this diagram in every single one of them. This is the evening, this is the webinar series that's going to get you mindful on how to maximize core rhythmic stabilization. Individuals who don't know how to transition from flexion to extension, and they have the best abdominals in the world. They've got the left floor as well as the right floor, but they don't know how to transition without either going into extension too early or flexion too late. So this is that transition period because their intercostal region is not rhythmic enough. Their stability is not rhythmic. It's not co-contracting for diagonal activities that are related to appendages. So if I do these three activities that you're going to see with this young lady, when we get done, her ability to spread her arm and her leg away from each other is going to increase by doing these three techniques. Her ability to allow her abdominal wall, her serratus function, and her other parts of her body to allow her to expand is going to improve. because the rhythmic stabilization is high enough in her chest wall that she can let go the tension and the tone that's required for that paradoxical diagonal activity that we're going to decrease by these three techniques. As I said in our last session of the seminar series, I'm going to go through all these 10 that I selected, but these three are very, very important techniques. They look very simple, but it will make them a challenge for any of your patient after Jen reads the first one.
Standing supported bilateral posterior mediastinum expansion. Stand facing a desk or a countertop and place both hands on the surface in front of you. Keep your feet shoulder width apart and knees slightly bent. Maximally round out to your back as you tuck your bottom under you. As you inhale through your nose, gently press down into the surface as you attempt to fill or expand your upper back with air. Exhale through your mouth as you maintain this position. Hold this position while you take 4 to 5 deep breaths in through your nose and out through your mouth, attempting to fill or expand your upper back with air upon each inhalation. Relax and repeat 4 more times.
Now, we're asking her to hold. We do this in a lot of our techniques, hold and press down. So keep that in mind. If you go to the next slide, rhythmic stabilization means you either hold or pull, but it's isometric activity. Alex is in an isometric state. She has dorsiflexion going on in her ankles. She has extension in her wrist. When you perform rhythmic stabilization using PNF techniques, the therapist or the movement specialist is always asking the patient or client to pull an extremity or body toward resistance that's applied by agonistic muscle contraction. In this case, in this technique, the agonists are the external intercostals that are pulling the hands and the palms to the countertop. That was step 4. By holding this position upon exhalation in step 5, the antagonistic internal intercostals are now engaging without movement of the rib cage going into more of a collapsed state or inwardly direction. And that is so big. Now Alex is learning how to force something down as she breathes in under force. So that body's ability to generate inhalation and exhalation without overusing extrinsic muscles to do so is going to give her the little edge she needs to move with that same type of activity as she puts her own body weight on the floor to hold herself up. So the weaker muscle, the agonistic weaker muscle of external intercostals did not break. It did not give. She held it. Or the ribs did not fully collapse upon the previous exhalation effort. It did not break. It did not collapse. And thus, air moving into the chest wall upon the next inhalation sequence will have a more overall expansion influence on the entire system and the stabilization and on the stabilization of that chest wall. It is micro, it is minor, it is minimal that makes everything macro and general and expand and felt. It's this micro activity that's going on at that level between those ribs that says to that nerve underneath that rib, it's free to breathe under force. It's free to move under force because it's like Dorothy and Margaret doing rhythmic stabilization of an arm or a leg or a trunk by saying, push, 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 don't hold, don't break, don't break. Hold, 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 don't break. No matter where she would put that arm and put that pressure, don't break. We're doing the same thing with these ribs. Don't move, don't break, but breathe in through your nose appropriately, blow out appropriately through your mouth, and don't break. As you constantly push the weakest muscle fiber down, the weakest muscle fiber down are those internal intercostals that are pushing down upon exhalation. Step 6 asks the patient to hold that position while attempting to fill or expand the upper back. So don't break. Keep it down. Keep it down. Don't break. Don't move. Hold it. Push, push, push. Using the external intercostals as agonistic muscles. Again, in this rhythmic stabilization process, as the hemidiaphragm is now what? At the same time? Pulling, pulling, pulling. One set of muscles are pushing, the other set of muscles are pulling, and what you've got is beautiful movement of airflow diaphragmatically going into a chest that is held stable, not overstable, but stable enough for it to what? Expand. That's the key. If you can get that intrinsic level to be felt at that level, all your extrinsic activity standing upright with gravity is going to be a piece of cake, because you don't have to use your other extrinsic muscle to keep you stable anymore, Louise. You just did it. You know where you're at. How about if you write this down? Interoceptive sensory sense of yourself. I'm me again. I've got a chest wall. I know who I am. I own me. I own my body. Wow, I actually can feel movement. I didn't even know those ribs could move. Very important technique. Very important technique. Both sets of intercostals are now engaging in rhythmic stabilization of the rib cage for diaphragmatic breathing without rib depression or collapse, without rib elevation or overexpansion. We call that the first week hyperinflation. If you want to reduce hyperinflation, try this, because not only are you going to reduce hyperinflation, it's not going to come back when you start moving around. Nobody really appreciates these techniques because they're not moving enough. They're not experiencing enough. They're not doing enough. But what you don't know is there's so much going on that they can't even handle it. They can't figure out how to give an isometric contraction with appropriate respiration for rhythmic stabilization of 12 sets of ribs to stay balanced with the rib cage when they start to move around. That balance, that rib cage, has got to be there at night when they go to bed too. I like to think in these COVID times, with these people that are really, really sick, and those that survive, go through weeks and weeks and weeks of rehab, do some reading, talk to a few people. It's not surviving that's the problem. It's the rehab after you survive it that takes so long, because their stabilization activity is not being directed toward the center of their body. That's going to require that once they get it back, it's going to require good diaphragmatic control again and instant relief of overcompensation with things that they cannot do because they don't have the stability from their intrinsic fibers between the ribs themselves to allow that expansion. Betsy, I see something up here. It says, what does he mean when he says it attaches to ribs 1 to 11 and 2 to 12? I missed that. What does that mean? It means simply this, that between each rib's bottom surface and top surface, there is a muscle fiber that is not horizontal, not vertical with the wall. It's at an angle. And when it contracts, that muscle wants to move one rib on the other rib, either forward or back, depending on where that muscle is laying. At the same time, Betsy, there's another fiber going the opposite direction. So that movement is rhythmic. It's so slight, it's rhythmic. It would be like a bicep and a tricep stabilizing a humeral bone. One's counteracting on the other. That stabilization I recognize in humans who can stand and do things like this with dorsiflexion on my left ankle and wrist extension on my right. No abdominal oblique, Betsy, is going to do that without intrinsic control of intercostals. You can have the best abdominals in the world, and you're not going to be able to do this because your chest can't expand, Louise. I can't expand because the intercostals don't have rhythmic stabilization. Patient and client could push the right lateral border of the hand. As I said earlier, I'll give you one example. The more lateral you become minded with these two sets of muscles in the wrist and the ankle, the more effective you're going to be. The patient client could push the right lateral border of the hand down more on that table for more inhalation effectiveness during external intercostal stabilization on that right lateral border of that right hand. That's the hand we should be looking at. Even though they're down here, they're still beginning D2F. because their wrist is extended. They're ready to, Louise, to what? They're ready to do what? But they're pushing down. That's a D2F pattern. Or the patient client could generate more push on the left lateral border of the left foot for more exhalation effectiveness during internal intercostal stabilization. Push down, push down, push down on that left foot, Alex. Don't let it go. And while you're doing it, you're doing such a good job, could you just push down firmer on the outside? Now we're getting into specifics. This is called magic. Patients are going to feel so much more different. We're taking PRI techniques and we're now specifically giving you instructions, if you're a PRI person, related to intercostal effectiveness. Or the patient client could do both. They could do both. They could do right wrist and left ankle, right wrist and left ankle for rhythmic stabilization of both sets of intercostals during reciprocal rhythmic breathing. There are so many things, if you truly understand Dorothy and Margaret, truly understand them, there are so many things in life that we can do so much better effective work with. But first, Louise, we got to have an appreciation for biased patterning, which is the first 6 weeks of this webinar series. We're now into the week that says, if you get this, and this was a very complicated discussion, Jen, but if you got this evening, next week's sensory awareness is going to make a lot more sense, because we're still talking about the same individual that now can push with forced respiration, but doesn't now know what it feels like to do so without force. Without it. I want to learn how to do that without force. We have 2 more techniques. This one's called the standing supported bilateral IO and TA. We won't have time this evening to actually read it, but I do want to make a couple comments that I left in your materials that you have. This technique could follow the same instructions regarding the rhythmic stabilization as outlined above. However, it's important to know that it implements more internal rib rotation synergistically from the dorsiflexors, and therefore assists more with antagonistic activity from the internal intercostals during exhalation than the previous technique. Provided the individual performs this technique, the technique doesn't lose control and stability offered by the external intercostals during inhalation phases of respiration while in the squat down position outlined in step 4. In other words, they take a breath of air in and they start to extend their back. You know they're over with. So a wonderful technique. It's a wonderful technique to implement internal rib rotation, which is exhalation, getting air out. And it's going to do so by using the wrists, not the wrists, the dorsiflexors of the ankle. This technique, the standing wall press, is just the opposite. This is a wonderful technique that could follow the same instructions as we did in the first technique. However, it implements more internal rib rotation synergistically from the wrist extensors, and therefore also assists more with agonistic activity from external intercostals during inhalation. So if you have somebody that really doesn't know how to breathe in without extending their back, do this one. If you have somebody that doesn't really know how to blow out without extending their back, do the last one. That's how I think. That's how I wish everybody would think. You can't treat rhythmic respiration if you don't understand rhythmic stabilization. And rhythmic respiration stabilization follows distal activity drive, which is diagonal PNF patterning. The individual performing this technique has to concentrate on how to continue to engage pressure or push on the wall, not the floor, from the wrist, the palms, during inhalation without losing control of the internal intercostals during the exhalation phase of respiration, which makes it a rhythmic stabilization process, while maintaining the background in this position as outlined in step 4. I want to thank you again for being here with me this evening. I warned you this was going to be very heavily packed, a little over an hour discussion. I had fun doing this. I always have a lot of fun putting these together. I'm going to be disappointed when this is all said and done, because I told Jen I actually get to talk about some stuff that I'd never get to talk about. And this is one of those evenings. So thank you for joining us. Next week, Jen, the title is?
Somatosensory processing of respiratory-based right thoracic rotation and expansion.
And again, please join me. It won't be as intense as this one, but I think it'll be as much fun for me. So please come. Got one more question? Is that it? Is there a question there?
Just a thank you.
Hey, Jen, thanks a lot for producing this evening. I appreciate you getting it all put together. I walk in here, I'm ready to go. You guys, thanks for attending this evening. I appreciate you all being here. I'll see you next week. Have a good evening.